even though the eco guidelines seem to say that there's no role, I have several of my patients who work in Europe, in the Netherlands, in Denmark, and there the physicians still use Pentasa. That's their main drug which they seem to give for IBD patients there. And so there's a disconnect between the guideline and what actually happens in practice.
Was there something because the incidence of malignancy was less in those who continued? There was one paper long back. Is it still true?
Certainly that's true for ulcerative colitis. I do not know about Crohn's.
So, I mean, whether there's value to chemo prevention in Crohn's or not, I think we don't know. I do still use mesalamine in a small proportion of my patients with Crohn's. I think one of the biggest undefined areas in Crohn's, and we're working as part of some groups to try to define it better, is we don't have a good definition for what is mild Crohn's. Right? A lot of the guidelines and studies focus on sort of moderate to severe Crohn's and the normal trajectory of that Crohn's, where there's no data for 5-ASA. But we know there are probably many patients who have asymptomatic aphthous ileitis or a few small aphthous ulcers on your colonoscopy that you see when they get a scope for mild diarrhea or abdominal pain, who could probably go for 5 or 10 years with absolutely no treatment and never end up needing surgery or never end up hospitalized. And so we're actually trying to develop criteria for what defines mild Crohn's. And I'm sure there's a reasonable number of patients in that mild Crohn's who will do just fine with 5-ASAs and be okay. So I don't think the choice of the initial drug is as much of a problem, as I tell my fellows, as monitoring to make sure you assess whether they're objectively responding or not. So if you're using 5-ASAs and their colonoscopy 6 months or 12 months after is still inflamed, then you have an answer. What you don't want to do is just put them on 5-ASAs and say, come back when you're symptomatic, and have them show up with complications a few years later. As long as that monitoring part is okay, I think whatever your first drug is fine.
Sure. So one of the questions that's always, which a lot of people keep asking me, is about azathioprine, because there's a lot of fear still about the use of azathioprine. If I can just invite Dr. Rohan Yeverle to briefly talk about our experience with azathioprine, a shorter experience.
Thank you, sir, for this opportunity. So I would just like to present something, a study which we conducted in our institute over the last 6 months. So we are all well aware that azathioprine forms the cornerstone of treatment in the maintenance phase of inflammatory bowel disease, and also acts as an adjunct to biologics. The ECHO guidelines do assert that there is a lack of evidence to form recommendations regarding the long-term efficacy and safety of azathioprine, and reasonably there is apprehension amongst patients as well as caregivers regarding this aspect of azathioprine, whether they should be taking it long-term or not. So what we did is we analyzed azathioprine use and outcomes in a mixed cohort of IBD patients, which were followed up over a long period of time. So this was a retrospective analysis of 472 IBD patients conducted at the SIMS Hospital, Chennai. But these patients were both historically on azathioprine as well as initiated on azathioprine at our institute between the year 2013 to 2022. And we analyzed for some hard endpoints and outcomes, such as long-term compliance, tolerance to azathioprine, the occurrence of various types of adverse events, and the subsequent amendment to treatment with regards to azathioprine. We also analyzed for certain clinical outcomes at the point of last follow-up. We classified, we defined certain endpoints such as durable clinical remission for those patients who became corticosteroid independent or did not require more than one course of corticosteroids, and we called it as durable clinical remission. We identified patients as non-responders when they were having continued disease activity or continued to require steroids. So this is a line diagram which shows a duration-wise exposure of azathioprine in our IBD patients. We had a cohort of around 320 patients on azathioprine, of which 256 were of Crohn's disease, and they had a subsequently more significantly prolonged duration of follow-up. So just to summarize the relevant data from our study, so out of the 320 patients who received azathioprine, the median dose of azathioprine in our study was 1.8 milligram per kg. What is noteworthy is this dose is lower as compared to what is used in Western countries, which is recommended dose being 2 to 2.5 milligram per kg. And but there have been studies in the Japanese population. There was a recent study which showed that despite using lower doses of thiopurines, they still end up achieving clinical remission. And that is what we saw in our study, that 72.6% patients did achieve the endpoint of durable clinical remission. The duration of azathioprine use in our study varied from 3 to 421 months, with a median of 33 months, and we had an overall 1,369 patient years of azathioprine exposure, for which we analyzed various outcomes. What we saw was there was relapse of disease despite initiation of azathioprine in around 38% patients, and a very small percentage, that is around 10% of our patients, ended up requiring some form of surgical intervention despite being on azathioprine. And the surgery need not always be colectomy. There were some surgeries for fistulas, and this was all inclusive. So coming to the adverse events, what we saw is 20.6% of our cohort experienced some form of adverse event after initiation of azathioprine, with myelotoxicity or cytopenias being the most commonly observed adverse event, which was seen in around 7% of the study cohort, followed by gastrointestinal intolerance, that is vomiting, abdominal pain. Now these may not be a major adverse event, but quite often they preclude the subsequent use of azathioprine in our patients. And what we saw is the median time to onset of adverse events was around 6 months. Another point which is noteworthy is when we analyzed the cumulative incidence of adverse events in our cohort, we found that majority of the adverse events occurred in the first 12 months of therapy, and with only 1.2% of adverse events occurring after 5 years of therapy. So these were some of the treatment interventions on encountering an azathioprine-related adverse event. These included dose reduction, temporary withdrawal, and discontinuation in majority of our patients. And based on this, since we did not have access to thiopurine metabolite testing and NUDT or this TPMT testing for a major part of our study period, that is counting from 2013. So since we did not have that access, this was a more physician-based judgment on whether the patient is having a dose-dependent or a dose-independent side effect. And based on that, we classified our patients having to have dose-independent side effects in 60%. And these could not be reinitiated on azathioprine, whereas 40% could be reinitiated. The other reasons of discontinuation of azathioprine in our study population was self-discontinuation. Now, there is a certain apprehension in patients to continue azathioprine for a longer dose. There are reports, if you Google search, there are reports of malignancies, and this is some question which is often asked by patients to the doctors. And there were patients in our study, around 21 patients, who self-discontinued azathioprine. And when we followed up these patients, 75% of them ended up having a breakthrough symptom immediately within the first 6 months. The other reason for discontinuation was durable clinical remission. This is a survival curve of patients who withdrew azathioprine due to various reasons. This included side effects, self-discontinuation, durable remission, pregnancy, ongoing treatment for infertility, surgery, or switch over to biologics. What is noteworthy in this survival curve is that after 7 years of therapy, there was only a 2% dropout in patients. So once a patient tolerates azathioprine for a prolonged period, that is around beyond 5 years, there's a significantly less attrition as compared to the beginning after initiation of therapy. Just to summarize our results, so of the 507 patients of IBD seen at our center, a mixed cohort,